All right, welcome back everyone. We are going to head into our last segment of the morning. I am Helen Parsons. As Beth mentioned this morning, I am an associate professor in the Division of Health Policy and Management at the University of Minnesota. I have been working with SEER-Medicare data for well over a decade now, and most of my work centers around measuring and evaluating the quality of care for cancer survivors. So with that, I'd like to get started on what I would say was a very challenging segment to really pare down into an hour. So today we are going to look at how you identify and measure cancer-directed therapy within the SEER-Medicare data. Now we had a number of different options for which therapies and treatments to include. However, just given the scope of today and that it was a one-day workshop, we really decided to focus on 3 of the most common cancer-directed treatments that researchers tend to study within the data. So today we'll be looking at cancer-directed surgery, radiation therapy, receipt of chemotherapy or biologics, as well as how you might measure a combination of these 3 types of therapies. So let's step back and take a 10,000-foot view of what is it that you are actually able to measure within the SEER-Medicare data as it relates to cancer-directed therapy. So in many cases, SEER and Medicare both measure cancer-directed therapies, but they do measure them differently. And so that's really important to keep in mind as you're trying to think about which source you might consider using for your study of interest. Importantly, it's very critical to understand the similarities and differences between the 2 data sources in what they measure and how they measure it to decide which measure will be best for your study, as well as what to do if the 2 sources point in different directions. For example, one source might say that this individual received cancer-directed surgery, and the other source may have no evidence of that surgery. So you'll have to decide what you will do when those 2 sources conflict. Before we dive into each of the individual types of therapy, let's step back and consider why we would measure treatment. What is the benefit of measuring treatment, and what are some applications for using it to understand care patterns in this population? Many researchers often study treatment in order to understand who gets what and variation between treatments across populations. You may be interested in evaluating variations in treatment or guideline concordant care across region or across demographics. You may also be interested in evaluating whether or not a procedure or a new procedure, an established procedure, influences outcomes for individuals with a particular type of cancer. This allows you to step back and look at real-world effectiveness of some types of treatments. And this is in comparison to information that you might have from clinical trials where you have a much more selected population. So this allows you to look at a much broader level on the impact of a treatment on outcomes for that population. You're also able to assess the quality of treatment that individuals receive and look at the quality across a full range of care settings. One of the major strengths of having the Medicare data is that you have treatment records for individuals across all treatment settings, including inpatient, outpatient, physician services, and so you can really see a much broader picture of the care that individuals receive across their cancer continuum. You're also able to ask questions such as, are there long-term consequences of treatments? And Stephanie will get into this later in the afternoon as we look at outcomes. Additionally, you may be interested in evaluating determinants of outcomes. Do certain therapies affect outcomes for individuals differently in one setting versus the other? Or are there disparities in outcomes in different populations? With that in mind, let's move into each of the 3 types of cancer-directed therapy that we discussed. So first, let's focus on measuring cancer-directed surgery. If we step back and look at the big picture, where can surgery be measured in this data? You really have two options, but they're measured in different ways. Both SEER and Medicare sources could be used and are often used to understand cancer-directed surgery that individuals receive. For the SEER data, you have a predefined list of procedures that an individual received. However, there are no dates. So if this is critical to your study, you'll want to focus on the Medicare data in order to identify surgery. Additionally, only the biggest operation is noted, and we'll look at some examples of that in a moment. Overall, it's a much easier value or variable to identify surgery, but it is more limited in the information that you're able to obtain. Medicare data also allows you to look at cancer-directed surgery in a much more detailed way. You have detailed billing information about all of the surgical procedures that an individual has received. However, it is more onerous in many ways because it does require you to create a very specific set of definitions and treatment windows based on coding and billing rules for the Medicare program. Overall, it's more complete, but it is more difficult to use, and this is where a lot of the analytic time can be used to create these measures. All right, let's focus first on how surgery is measured in SEER. As you'll remember from earlier this morning, Beth mentioned the definition of first course of treatment. So SEER collects first course of treatment and only includes surgery that was performed as part of that first course of treatment. As a reminder, the definition of this is that the first course of treatment includes all methods of treatment recorded in the treatment plan that were administered to the patient before the disease progressed, recurred, or there was a treatment failure. Overall, since approximately 1998, it includes all planned surgeries or surgery within 1 year if there was no evidence of recurrence or failure. One thing that I will highlight, and this applies to all of the staging as well as the treatment variables that are included in that PEDSEF file, is that it's very important that you go back and consult the SEER program and coding staging manual for individual details. Many of the variables and the definitions will evolve over time, and the definitions and the coding will evolve over time. So if you're looking over a range of years in particular, you'll want to make sure that you're very clear about what those definitions are over time so that you're really understanding what you're getting from that definition and that variable. Next, let's look at what's actually coded in the SEER surgery variable within the PEDSEF file. SEER only codes the most extensive procedure that was performed, and it follows an established hierarchy. So, for example, let's look at breast cancer. As an example, an individual first received a biopsy. They then went on to receive a lumpectomy and finally a mastectomy for their breast cancer. The only procedure that would appear in the SEER surgery variable would be the mastectomy that occurred, so the most extensive procedure of those three. You are not able to determine the course of events or the order of events or even the timing of events, just the most extensive procedure. In addition to this, there's no information about the provider available within the SEER data. And this may be an important characteristic, especially if you're looking at provider patterns or networks of care. So this may be a limitation of the SEER variable if that is an important component of your research question. What is available within the SEER surgical variables? Keep in mind that there are a number of different variables that you may select to be able to more fully understand the surgery that was delivered as reported by SEER. There are a set of separate variables for the surgery of the primary site. You also have additional information about the lymph node evaluation, and we'll get into details about that shortly. You have information about surgery to distant site and reconstruction for all organs. Importantly, as I noted before, many of these variables are site-specific, so you'll want to consult the SEER program coding manual to ensure that you understand what the value means for your specific cancer of interest. A value of 1 for oral cavity may be different than that of ovary. So be very clear and consult those manuals to make sure you understand what surgery is being described by certain values. Additionally, you'll want to be very cautious as you're looking at trends over time, particularly if you're crossing over between pre and post 2004, as there was a change to collaborative staging, which was a system of coding staging within the SEER program. So if you see trends and changes in treatment patterns and staging patterns before and after that point, it may not necessarily be due to changes in the underlying distribution of disease or the treatment patterns, but may be an underlying difference due to the changes in the staging process and the staging manuals. So make sure that you, again, check those coding manuals to make sure that you understand where those changes occurred, when they occur, and what those values mean. As they're continue to be, we fully expect that there will be continued updates over time as more information becomes available and as the SEER registries evolve. As I mentioned before, there is information on lymph node evaluation. It is only available in the SEER data. You do not have a comparable measure within the Medicare data. So if this is of interest to you, this would be the area where you would focus within the SEER data. You'll have information on whether there were lymph nodes examined. So you can see whether or not there were 0, 1, 2, 3. So you'll be able to know whether or not they were evaluated and how many. You'll also be able to know whether or not those nodes were positive, as well as how many were positive. Note that these variables are only available for certain years and certain cancers, and you can consult the PEDSEF file for more information regarding that. As I mentioned before, you have to keep in mind SEER coding changes that may have occurred over time, particularly if you're noticing major trends in treatment or staging over time. So you'll want to check before and after 1998 and 2003, as there were major changes in how staging and treatment were reported. Now that we've looked at how SEER measures surgery, let's move on to understand more fully how you can identify and measure surgery within the Medicare data. Depending on your measure of interest, you may need to use multiple files within the Medicare data to identify surgical measures. So let's look at some examples of what you might expect to find. If someone was treated in an inpatient setting, so someone who was hospitalized for their cancer-directed surgery, you will find at a minimum 2 bills for that therapy or for that surgery. First, you would find a hospital bill, and this would show up in the Medpar or hospitalization file. That bill covers the room that the patient is in, their nursing services, and all of their other ancillary services that they receive while they are admitted as an inpatient in the hospital. In addition to that, you will find a physician bill for the physician who actually performed the surgery. This would be found in a separate file due to Medicare's billing and coding rules. And so you would look within the NCH, the National Claims History, or the carrier claims. You'll hear a number of times, as we've mentioned before, that this particular file has undergone a series of name changes over time, but they all refer to the same file. If someone is treated in an outpatient setting, meaning that they were never admitted for their therapy, you will find a minimum of 1 bill, but this would be found in a different file. This would be found in the outpatient facility bill, and this would cover both the physician performing the surgery, the surgical suite, and the nursing services and other ancillary services that occurred during that treatment. Keep in mind, and we'll look at some examples in a moment, that Medicare reimburses for these services using distinct billing codes and fee schedules depending on the setting, and they don't cross settings. So you'll have to keep that in mind as you're looking for evidence of treatment between the different settings. Okay, so how do they show up in the data? Let's first look at the hospital bills that you'll see within the Medpar file. So hospitals bill for surgical services using ICD-9 procedure codes. And if you'll remember from earlier, the Medpar file includes one line per hospitalization. So each hospitalization will allow you to code up to 25 procedures. So you would look within each of those 25 procedures for an individual who is diagnosed, and then you will be able to find an associated procedure date. So you'll be able to know the procedure that occurred and when it occurred, which is more information than you do have within the SEER cancer surgery variables. Let's say then that you're interested more in outpatient surgical care, or the surgeons that perform the surgeries. Outpatient and physician claims code for services using a different billing system. So and they bill using current procedural terminology or HCPCS codes, and those are just Medicare codes. So in general, most of those services are billed in subcomponents. So you would see a separate bill for the surgery, the surgeon who actually performed the surgery, but then you would also see another bill for the anesthesiologist, the pathologist, and the rest of the surgical team. These files also include procedure dates as well as the performing surgeon identifier. So if you're interested in that component, you would want to look into this set of files. One thing to keep in mind if you're thinking about processes of care or care that occurs along the cancer continuum is that not all services will show up as a separate line item within the Medicare claims. Specifically, there is this concept of bundling, which refers to paying surgeons a global payment for the routine care related to the procedure. And this includes both the preoperative and the postoperative care that may be associated with a particular surgical procedure of interest. So one thing to keep in mind is that when this happens, they get a single payment for providing that routine care around that surgical procedure. So they don't necessarily, you will not see whether all of that preoperative care or postoperative follow-up visit if only minor problems are happening. There are a set of rules that you can find within the Medicare coding and claims processing manuals that will allow you to understand what exactly is included in that bundle and what you would expect to just see as a single bill for that bundle versus what would be billed separately. So it's really important that you'll become familiar with the Medicare coding and billing rules. One thing to note is that major problems are not included in the bundles, and so you do see those as a separate bill within the claims. Also keep in mind that the bundling rules do change over time, and so again, consulting those manuals to ensure you really understand what is included in the bundle. So if you suddenly see an addition of all these other ancillary services showing up, that it may not be truly a change in patterns of care, but just a change in the billing rules. You'll want to understand that. Additionally, anesthesiologists, pathologists, and the imaging that might occur preoperatively or postoperatively are not subject to that bundling, so you do see those separate bills within the data. As I hinted at before, there is not an exact match between the coding and billing, the coding systems between the different files. So depending on what level of granularity you may want to understand the surgery of interest, you may want to select different data files to really understand and drill down about more information related to that surgery. So let's just take the example of lymph node evaluation. As I mentioned before, within the Medpar or the hospitalization file, they bill using ICD-9 procedure codes, which tend to be much higher level, broader, all-encompassing codes, and it may not provide as much information as you would like. Whereas within the physician or the carrier claims as well as the outpatient claims, you they bill using the CPT or the current procedural terminology codes, and that does allow you to get at a little bit more granularity related to what may have occurred within that lymph node evaluation. So just keep that in mind as you're trying to understand what coding system and how you'd like to identify your cancer surgeries. Okay, so now that we've covered what's available and how you can identify surgery within SEER and Medicare, let's take a look at the agreement between the two data sources. So we pulled together a cohort of some of the most common cancers. So we took those who were diagnosed with breast, colon, and lung cancer within the 5 most recent years of the SEER Medicare data, who were likely to have complete claims. So those are the individuals, as Christy mentioned earlier, that are enrolled in Part A and B, that did not have any evidence of enrollment in an HMO, and some other exclusion criteria within 4 months of their diagnosis. And we looked across a combination of their hospitalization or Medpar bills, their physician and hospital outpatient files. And here you can see the overall agreement between SEER and Medicare in 2 areas. First, we looked at whether or not, on the right-hand side, they agreed regarding whether or not those individuals had a surgical resection for their cancer. And overall, you can see fairly high concordance between the 2 sources, which ranges from about 70% to 90%, depending on the cancer of interest. You also see fairly high concordance, but there is some significant variation between SEER and Medicare on whether or not an individual had no surgery or biopsy for their cancer. So keep in mind, mainly due to the differences in their definitions and what they consider as an included therapy, that we do fully expect to see differences between the 2 data sources, but overall there is good concordance between the 2. Okay, so the key takeaways for measuring surgery. Overall, both sources could provide information for your study related to cancer-directed surgery, but they measure different things and have different levels of granularity and information. SEER provides high-level first course of treatment, so you have very general site-specific codes. If you're just wanting to create a high-level measure of yes or no, this individual received cancer-directed surgery, this may be the measure for you, but it doesn't include physician or provider information as well as procedure dates. So if those are critical for your study question, you'll need to focus on the Medicare claims to identify your cancer-directed surgery. The Medicare claims allow for much more detail. You can measure the dates of surgery, the performing surgeon. You also have information about the reimbursement for those procedures. And Stephanie will talk about that and measures of cost later today. You also can identify more detailed information on the procedure. So if you are interested in a very specific component of a procedure that it can only be identified through a CPT code, you would want to focus on using the Medicare data to identify your cancer surgery. You're also able to be very specific about your windows and when you would like to look for cancer-directed surgery. So if you're considering questions around quality of care or timing of treatment, this could be a good source of information for you. Additionally, some researchers decide to use information from both, and that's really up to the researchers depending on their study question. Now let's move on to how you may identify radiation therapy within the SEER-Medicare data. As with surgery, you have 2 choices for identifying radiation therapy within the linked SEER-Medicare data. Both SEER and Medicare provide information on radiation therapy. So for the SEER data at a very high level, you have a predefined list of radiation therapy categories. You are also able to identify the sequence with surgery, but again, you have no dates to provide information on when that radiation therapy occurred. And again, it only includes therapy provided as the first course of treatment. So overall, it's easier. You have more of a high-level measure, but it is more limited and may not capture all of the radiation therapy that was provided to that individual. The Medicare data, on the other hand, do allow, as with cancer-directed surgery, much more detailed information about all the procedures that individuals have received, but it does require creating definitions and windows. So there is a lot of analytic time and energy that would go into creating that measure based on all of the coding and the billing rules for Medicare. As I mentioned, it's more complete, and you have much more detail on the dates of service and the dosing, and we'll get into some of those examples in a moment. Most of these claims will be found in either the outpatient or the carrier claims. So if you're trying to pinpoint which files you would need for your study and need to request, those are the files you would want to focus on for radiation therapy. Let's first focus on how radiation therapy is identified and measured in SEER. SEER only includes radiation therapy provided as a first course, and in many cases, again, this would be up to the researcher to go back into those SEER program coding manuals to understand what that definition and treatment window is. Historically, it had been the first 4 months after diagnosis, all the way up to 12 months, but it depends on what year that individual was diagnosed. There are a number of categories, again, very high level, that SEER reports for radiation. An individual could be reported as having no radiation, having radiation used. There's a number of different categories at a high level, that they had refused radiation, that it was recommended but unknown, or that you had missing information. Even though the categories are reported, there is no implied information on dosing within this particular variable, as well as information on the intended target. So you don't know from this variable if the intended target was the primary tumor or whether or not the radiation was directed towards secondary spread. Within the categories of radiation, you can classify between whether an individual received beam radiation, radioactive implants, radioisotopes, or a combination of those with one of the others. You also have this very useful category of radiation type not specified or other. You can decide what you would like to do with those. There is also information on the timing of radiation, but only relative to surgery. So you can determine whether or not radiation, according to SEER, was administered prior to or after surgery, both before and after surgery, intraoperatively, or with other radiation. You may also have information about whether or not the sequence was unknown, but that it was provided. Next, let's move on to how Medicare bills for radiation and how you'll see it appear in the Medicare data. As with other procedures, radiation is billed separately for each of the treatments that were administered, so you're able to evaluate dates of service as well as dosing. And we'll get into some of the caveats with dosing in a moment. Based on billing codes, you are able to differentiate and find combinations of external beam radiation, brachytherapy, IMRT, or proton beam radiation therapy. And you may be interested in any combination of those, or just a more general measure, depending on your research question. So you might ask, well, how do I actually find radiation therapy within the Medicare data? There's a number of different places. We mentioned before that most bills are found in the outpatient and the carrier files. However, you will find some evidence of radiation therapy within the hospitalization files. These are very general codes and would not allow you to really differentiate between the different types of therapy or the dosing. So if you just need a general measure, you may consider adding the hospitalization information related to radiation therapy into your measure of radiation treatment. Within the outpatient and the carrier files, because of the way that the claims are billed, you have information and are able to distinguish between different phases of care within radiation therapy. So you can see bills for any of the initial imaging that occurred leading up to radiation therapy, planning that may have occurred. So as an example, there's a CPT code for a radiation physics consultation. You're also able to see the actual treatment delivery, so the actual radiation treatment as well as the dosing, depending on the level of detail that may be included within that CPT code. You'll also see information on the oversight or the radiation management by the physician who's overseeing the radiation therapy, again, based on the CPT code. Overall, the CPT codes, so those that you can find within the outpatient and the carrier files, allow you to evaluate and understand radiation therapy with the most detail. And importantly, those charges do occur at all points in radiation therapy, so you do see a separate bill for all of the different components. You can really see and step back and see more of an overarching approach to the radiation therapy. One thing to keep in mind is that, as with all services in Medicare, the billing codes are added and discontinued over time. So make sure that as you're preparing your list of codes that you're going to include in your study, you evaluate them carefully to make sure you aren't missing a code. Oftentimes we'll have researchers come and say, oh, I saw a huge drop-off in the number of individuals who had radiation therapy from 2006 to 2007. And then when you really go back and you look in their data and their list of included codes, it's really not necessarily that there was a true change in the patterns of treatment, but just that, oh, by the way, there was a new CPT code that was added, and that's where the majority of physicians are billing for that service. Creating measures of radiation therapy, it can be very tricky, and it really depends on what you need to get out of the measure for your own research question. Keep in mind that radiation therapy can span several phases, so you have information about the planning, the monitoring, and the actual delivery of radiation therapy. So you can't necessarily just go in and grab a single code and expect to really understand the full course of treatment that occurred for that individual within the Medicare data. You really need to be thoughtful about ensuring that you have a full list of codes and that you understand the units that were used to bill for the therapy and the dosing, as well as the dates for when treatment occurred. Using this combination of information, and we'll look at an example here in a minute, you can build different algorithms to calculate and categorize either the types of radiation therapy. You may just only be interested in high-level buckets of the types, yes or no. They only received external beam radiation, yes or no. You may be very interested in understanding the radiation therapy consultation of planning and those that received just the planning but no treatment. But you'll have to think about what exactly that means in practice for creating your algorithm. You might also be interested in those who had incomplete treatment. But then you'll need to think back and say, well, what would that mean? How many bills would I consider having incomplete treatment? And what does that mean for the quality of care? Could it be that someone discontinued? Or what are the other things that could have led up to that? And then you could be interested in whether or not someone actually completed their radiation therapy. Again, what's your definition of completion? How many doses would that be? Would it be somebody that completed 75% of the average dose of the average or recommended therapy, 80%, 90%, and then use that to back into your algorithm of how you would create those measures? One thing that can be particularly tricky is measuring radiation days or the number of services, and that's where there are some additional variables within the Medicare claims that are particularly useful for researchers to understand those components. There are a set of variables. So the first one is the MTUS, which is the miles times units variable, and that appears in the physician or the carrier file. And then there's a revenue center count variable that appears in the outpatient variable. So as you're thinking about, okay, I would like to measure the number of unique days that an individual received radiation therapy, or the number of services that they received over a 6-week period. What does that actually mean in practice? In practice, physicians have their own unique signature for how they may choose to bill for those services, and you may see the same number of services reflected in very different ways within the bill, but in reality, a patient may be receiving exactly the same number of treatments. So let's look at a few examples. Let's say that you have an individual who received radiation therapy 5 days a week for 6 weeks. If you're attempting to count the number of services that they have, you'll need to be extremely careful about what you're counting. So, as I mentioned, there's a number of ways that this could appear in the data, all with the individual receiving the same number of services. You may see one bill or line item for each day of services within the claim. So you would have 30 distinct line items or claim lines with an MTUS equal to 1. So 30 times 1, you would have 30 services. You may also see an individual who has one bill per week. So potentially the physician would be billing once a week, and you see 5 treatments for 6 weeks. So you only see 6 bills for this individual. But each of them have an MTUS value of 5. 5 times 6 is 30. You still have 30 services. Additionally, you might see one bill for a month with 20 treatments, so 20 line items. But then subsequently, you would see another bill with for 2 weeks of services with an MTUS of 10. So it really can show up a number of different ways, and you need to be very careful that you're not over or under counting the number of services or treatments that an individual received. One of the things that we often recommend is that as you're getting your data and you're trying to create your algorithms, that you might want to print off a couple examples, a couple cases, and work with your analyst to see, okay, how are these claims actually showing up in the data, and using that to really understand how you'll create your algorithm. One of the questions we oftentimes get is, should I assume that because I see a bill for radiation that it's targeted towards the primary site, or are there ways that I can determine that it's focused on the secondary spread of the cancer? If not, it does have implications for concordance between SEER and Medicare. So maybe this could be a way to study disease spread and palliative care. Let's just take a look at how this appears in the data. So we took a sample of individuals who had evidence of radiation therapy for the top 4 cancers: prostate, breast, lung, and colorectal cancer. And we said among those individuals who had bills for radiation therapy, what were the diagnosis codes that were listed on those bills for services? And you'll see here that they may not be as informative as you would like to try and understand and distinguish between treatment to the focus on the primary site versus secondary spread. Overall, the majority of cases do have a diagnosis code for that primary cancer of interest. You see some variation of reporting for other cancer diagnosis, and then a fairly large proportion that have just this non-specific radiotherapy diagnosis code. So this might not provide you with a level of detail of information to really understand what the primary target of radiation therapy would be. Just looking at it a different way, we broke out the primary diagnosis by the file where the radiation therapy was recorded. You really don't, you see a lot of variation here as well, but most of the therapy has an associated primary cancer diagnosis with, again, a large proportion, particularly within the outpatient file of this non-specific radiotherapy diagnosis. Okay. Now let's take a look and see what type of concordance we see between the SEER and Medicare data on radiation therapy. For this example, we took individuals who were diagnosed in 2014 with breast cancer and restricted only to those with their first and only cancer diagnosis. As with some of the examples that Christy presented earlier today, we limited to individuals who were likely to have complete claims. So we restricted to those enrolled in Medicare Part A and Part B in at least 1 month in 2014 and had no HMO enrollment in either 2014 or 2015, which was essentially their year after diagnosis. And we then looked for claims-based evidence of radiation therapy using a comprehensive list of ICD-9 procedure codes and CPT codes from the Medpar hospitalization file, the carrier file, and the outpatient file. This resulted in approximately 12,000 individuals who were likely to have complete claims. So we looked at it in 2 different ways to try and understand the concordance between both data sources. Overall, we've found very high concordance between the 2 sources. So if you use Medicare as the gold standard, we'll do this first and then we'll flip it. We are able to find SEER-based evidence of radiation therapy for 84% of the people who have Medicare claims for radiation therapy. Overall, very high concordance, and we looked at this within different treatment windows. You do see a drop-off in the concordance the longer we expand our treatment window, and this is expected due to, if you'll remember, the definition of SEER-based radiation therapy as it had to be delivered as the first course of treatment, whereas in Medicare, it would be any radiation therapy that was administered. Now, if we flip it and we use SEER as the gold standard, we are able to find Medicare-based evidence of radiation therapy for 90% of the people who SEER said had received radiation therapy. And you actually see the opposite trend when we flip this, and you're seeing higher concordance the longer we extend our treatment window. Again, this is not unexpected as Medicare includes all of the radiation therapy that an individual received. Why would we expect differences between SEER and Medicare? These are not unexpected, and they're due to definitions around how SEER and Medicare identify radiation therapy. More radiation therapy in Medicare sources may be due to a number of factors, including that SEER may not ascertain all of the radiation therapy that an individual received. As we mentioned before, SEER is primarily hospital-based, and so outpatient treatments that are administered to those individuals may be tougher to find and may not be complete. Additionally, you may see mismatches between treatment windows under Medicare and SEER. This is to be expected because of SEER's first course of treatment definition. Additionally, you may see radiation aimed at secondary cancer sites. Overall, less radiation is reported in Medicare than, if you were to find that less radiation was reported in Medicare than in SEER, this may be due to a number of factors, including that treatment was received from a non-Medicare provider, such as the VA, the Indian Health Service, or other private insurance where Medicare was not billed. In order to limit this, you may consider restricting your analyses to those that were likely to have complete claims. And this is just another example of why we're also always so careful and spend so much time on building our cohort in a way that we would only include people who we expect to find claims for their therapy. Overall, there are a number of challenges with measuring radiation therapy. One of the major challenges is that we cannot measure intent directly. So there is not a flag within the data that says this radiation therapy was curative or palliative. So you really would need to work within your clinical knowledge or also just practice patterns to understand whether or not you think you could make that reasonable assumption. But in many ways, you do need to make strong assumptions about what care is being delivered for what purpose. You also cannot identify the role of patient choice and whether or not a patient decided to end therapy early. There is some information within SEER that notes that treatment was offered but not accepted. However, this is likely incomplete and may potentially conflict with information that you would find within the Medicare claims. Most importantly, information regarding the quality is not available from either SEER or Medicare. So you don't have a variable that says, yes, this individual received guideline concordant therapy. You also don't have, so as a result, you have to measure this indirectly by creating your own algorithms and measures and making some clinical judgment about what seems reasonable. There are also technical and pathologic details that are beyond the scope of collected data. You may not have as much detail about the radiation therapy as you would like and the results of tests and scans. So for radiation therapy, our key takeaway is that, again, as with surgery, both sources do provide information on radiation therapy. Overall, we see generally high agreement. They provide different types of information and different levels of information. SEER provides very general radiation codes, which again provides a much easier way to create measures, but depending on your research question, it may not be detailed enough to answer and doesn't include physician or provider information. Medicare claims are more analytically challenging, and they require knowledge of which codes and will appear in the bills and what are the rules around how they're billed. But it does allow you to identify more detailed information on dates of therapy, so you could have time to event analyses, the providers who administered the therapy, as well as the costs of care. And finally, let's look at measuring chemotherapy or biologics in the data. When you're interested in measuring chemotherapy, you will need to look to the Medicare data. Chemotherapy information from SEER is not currently available in the SEER Medicare data because of concerns about under ascertainment. Within the Medicare data, depending on the therapy that you're interested in, it may appear in different files because of how Medicare covers different therapies. So Medicare can pay for chemotherapy or biologics in a number of ways. So Medicare Part B, so those are things that would show up in your outpatient or physician files, pay for chemotherapy administration and for specific drugs that are either given by injection or their IV equivalents or metabolites. Medicare Part D, on the other hand, pays for all other oral medications that do not have an IV equivalent. Remember that we only have data available from 2007 forward for the Part D program. So if you are interested particularly in Part D drugs, you will need to limit your analyses to only those years when the Part D data are available. There are a number of caveats with chemotherapy. Throughout this discussion, we'll be using this term very broadly to include all medications that are aimed at treating or controlling cancer. Please note that there are some agents that do have non-cancer treatment indications, and so you'll need to decide, as an example, their methotrexate could be used for treating other conditions. There's also the use of tamoxifen for cancer prevention. So you'll need to decide whether or not you include those particular agents in your study. In order to identify chemotherapy within the Medicare claims, you will likely be using a combination of multiple files. and this is based on CMS's policy for reimbursement. IV chemotherapy is typically found in either the outpatient or the carrier files, and you're going to see different codes depending on what is being done. So you'll see a code for both the agent, so you'll be able to see in a level of detail what drug was actually administered, as well as a code for the actual delivery of that agent. And this is by policy. Medicare allows for reimbursement of both components. Oral chemotherapy drugs, on the other hand, could be found in either the outpatient or carrier claims or Part D, depending on whether it has an IV equivalent. We're going to look at an example in a minute so you can see how they might show up. There are a number of challenges to measuring chemotherapy. While inpatient chemotherapy is available, there are no CPT codes within the inpatient files, so you cannot specifically identify the agent. You could include the inpatient file in your algorithm for whether or not someone received chemotherapy, but it would need to be a much broader measure, as in yes or no, because you would not know the specific agent for that individual if you were only using bills from the Medpar file. Okay, so let's look at an example of how the data would show up in the Medicare files. Let's say, for our first example, that we have a set of IV drugs or those that have an IV equivalent. Those fall under Medicare Part B. So, as an example, you would see fluorouracil or capecitabine. Those would appear in primarily the carrier files and the outpatient files, and you would identify those using CPT codes. As I mentioned before, you would also be able to identify that they received chemotherapy within the Medpar hospitalization files. However, they just report general codes for chemotherapy administration, and you don't know the exact drug. As an additional example, let's say that you have a drug that you're interested in studying that has no IV equivalent. This would be considered a Part D drug. So as an example, gefitinib, this would show up in the Part D data, the PDE, the Part D event data, and you would look for those drugs using the NDC or National Drug Codes. There may be other services or ancillary services related to chemotherapy and administration that you may be interested in studying. As long as Medicare allows for separately billing these services, they will appear in the data. Again, this will be based on CMS's policy regarding reimbursement for these services. You can identify equipment, so pumps or ports for chemotherapy. There may be evidence for prehydration or premedication, antiemetics. This will be very specific to reimbursement policies. So Medicare may pay for the antiemetic given within 48 hours of chemotherapy if the medication is given intravenously or orally as an alternative to IV. You might find drugs outside of this time range within the Part D data. Again, we would refer you to the coding and billing rules to make sure you would understand exactly how they could be billed and reimbursed to make sure that you would be looking in the right set of files to identify them. If you are specifically looking at chemotherapy in Part D, let's just review quickly what information is available and how it will appear. As I mentioned before, only chemotherapies that are available in an oral form, so those that do not have an IV equivalent, are found in the Part D data. But as you remember before from Christy's example, not all enrollees have Part D, so we do expect a reasonable loss of sample size due to this requirement, and there are differences in the individuals who enroll versus those who don't enroll in Part D. So you'll need to keep that in mind, and you can look at that based on your cohort demographic criteria. Within the Part D data, you do have information on the drug itself. That's based on the NDC code, the drug type, the dosage of the drug, the date the prescription was filled, and any co-payments and deductibles. that that individual was responsible for. However, you do not have information on the prescribing physician, the date the prescription was written, or the diagnosis relating to that therapy. For the diagnosis specifically, you could consider looking at other related Medicare files to obtain that type of information, but it would require requesting additional files besides the Part D data. So as with radiation therapy, you need to be extremely careful when you're considering measurement, particularly around dosing or trying to make inference around the regimen that an individual received. So it may, as I mentioned with radiation, it could appear in a number of ways within the data. If we use the example of the outpatient and the carrier data, you might see one bill or line item for each day of service. So each IV administration. So you would have 30 separate lines with an MT, a miles times units value of 1, or a revenue center count of 1. And for the second one, I realized this morning that I had a typo. However, I can just walk you through that one quickly. For here, you would have one bill per week with 5 treatments for 6 weeks. So in this case, you would see 6 bills with a unit of 5 in both the MTUS and the revenue center count. And in both cases, you would have 30 treatments or services. So they would be equivalent but appear differently within the data. You can note that the CPT code specifically for chemotherapy does provide some implied dosing information. So if you look at the description for CPT J9190 for fluorouracil, you can see that it was a 500 milligram dose of that drug. Within Part D, the data appear as 1 bill per prescription fill, and that's based on the NDC code. Again, you do have some implied information about dosing within that data. So if you look at what the definition is of that NDC code, you can see for gefitinib that would be 30 tablets and 1 bottle. You'll need to make some assumptions about the receipt of therapy and whether or not an individual will have actually taken the pills, but that information is available within the data. However, there is a caveat within the dosing calculations or creations of measures that might imply regimens. We've seen this in our own work, and I think that it's just something that we want to caution you about. Not all dosing that you will see that shows up in the data may fit within the clinical norms or practices that you're used to seeing. So you're going to need to decide how to classify these individuals and see if the dosing that appears in the data really makes clinical sense, or how you would like to classify those individuals. So we took an example of individuals who were diagnosed with colorectal cancer and broke them out by stage, looking at those who had any claim for irinotecan, and looked at overall what their median or daily dose was. And for over 50% of individuals, we found that over 50% of individuals had a single daily dose above 800 milligrams, which may not make clinical sense to those of you in practice. So you really just have to step back and consider, well, what do we do with these individuals? Do we think that those individuals really had that dose of therapy, or do we make some other assumptions about a threshold or some other measure for identifying chemotherapy and regimen? So the key takeaways for chemotherapy are that if you're interested in evaluating it, you'll need to look to Medicare sources to identify and measure the type of chemotherapy that an individual received. So with the exception of chemotherapy that is administered in an inpatient setting, you are able to identify both the drug that was administered, when it was administered, as well as those providers who provided the care. So you really do have some very rich information on that treatment. Now that we've gone through each of the 3 types of therapy, let's just take a step back to understand and think about why SEER and Medicare might disagree on cancer-directed therapy. I hinted at this before, But SEER may find that care is not covered by the Medicare program, but SEER would still include that in their definition of first course of treatment. However, because it was not billed to Medicare, it would not show up in the program, in the claims data. Additionally, SEER may have a harder time finding cancer care that's delivered out of a SEER area, particularly if there's no record of that care by a local provider. And finally, Medicare might find that care isn't considered part of the first course of treatment. However, it would not be recorded in SEER as treatment, but you would see it as a bill within Medicare. Overall, you are able to determine some aspects of cancer-directed therapy in both SEER and Medicare. We do expect that there will be differences in what's reported and what you see between the two data sources. Overall, there is generally good concordance between the two. Keep in mind that SEER coding of treatments does vary by cancer type and over time, so we're going to keep hitting on this again. Make sure that you reference those coding manuals to understand exactly what's captured and how it's categorized. And finally, Medicare coverage of cancer therapy is defined by policy, so make sure you understand what's included, what's covered, and what is allowable as being billed within Medicare, so that you would understand therapy that wasn't received versus that just wasn't reimbursable and may never have been submitted as a claim. This final slide provides an overall summary of what we discussed over the past hour, high-level descriptions of what you can see in both sources. You are able to identify surgery and radiation from both sources, and so you'll need to decide which source or a combination of sources you would decide to evaluate for your study. You might also be interested in a combination or sequencing of this therapy. For those types of questions, you'll want to focus primarily on using the Medicare data for those measures, as there really is only information on the sequence of surgery relative to radiation within SEER. So some final thoughts. Overall, SEER-Medicare does allow for high-level identification of cancer-directed treatment. You're able to identify surgery, chemotherapy, and radiation. But there is no gold standard for identifying therapy in either choosing SEER or Medicare, and your selection of a source may be different depending on your study. We do expect mismatches, and we do see them because of the scope of the treatments that are identified and their definitions between the two sources. Overall, remember that different sources of care, so if care is administered in an inpatient versus an outpatient setting, will have different coding conventions. And so you'll need to use different codes to identify that therapy, and they're going to be found in different files. So you don't necessarily have a single file that you'll go to identify radiation or chemotherapy. You'll need to use most likely a combination of Medicare claims. And finally, consider partnering with clinical experts to ensure that your treatment definitions fall within clinically valid or reasonable assumptions, including assumptions about your treatment windows or the included codes. And with that, I think we have time for a few questions before we break for lunch.
All right, so there were, again, a lot of questions. We'll just pick out a few. One question, is there a resource available that details the ICD-9, CPT, and HCPCS code changes over time so you can make sure you're using the correct code?
Well, there's a number of approaches that you could use. Within our team, we actually go on and purchase historical versions of many of the code books that we just keep on our file, in our library to reference and see. You can see when codes are appearing over time, and just using that as a reference. There are several searchable databases online you can consider looking. There isn't necessarily a single source. Within that, it typically tells you when the code became effective and when it was discontinued. One of the other sources we often go to are the coders and billers within our own institution to see how they may bill for different services. Sometimes it's not always what you would expect, but they really do have some very valuable information. And then going to the providers themselves to understand how they bill for procedures. And it may just be based on their signature for how they bill for things, but there are billing and coding rules around that as well.
All right. What if the measures of surgery in the Medpar are different than the NCH? Which one would you prioritize?
Mm-hmm. So if there is a variation between the two, it really will depend on your study question and what level of detail. So I mentioned this briefly within the discussion of surgery, but the Medpar uses ICD-9 procedure codes, whereas the carrier claims would use the CPT codes. Generally, the Medpar, those codes tend to be higher level codes, whereas the CPT may provide more detail about the procedure. So it really depends on what level of granularity you might need between the two sources, and then you could use that to distinguish. We always expect to find a little bit of difference. If one says, that they're having surgery for their colon cancer, and the other one is saying that they may have a breast cancer surgery, that would be very rare. But if you keep in mind that these are very large data sources, it may be a few hundred patients where you might see something that doesn't seem to align. Overall, if you were to remove them potentially in a sensitivity analysis, it may not impact your results that much. So you'll have to decide what you really want to do with those few individuals that don't line up.
All right. And then will chemotherapy treatments received in hospitals show up as CPT codes in the carrier file?
They will not. So you will only see they will only appear as an ICD-9 code within their hospitalization, but that any care that is received after their discharge from the hospital will then appear in the outpatient or the physician and supplier file. So they're separate.
Okay. And then would you recommend always including the DME file for evaluating chemotherapy use?
The DME, we didn't cover this because it is less common for the chemotherapies to show up in the DME file. However, they sometimes do. Usually it doesn't affect their overall measures of whether or not someone received chemotherapy. I mean, if it shows up as chemotherapy in the DME file, typically we would have also seen some bill for chemotherapy in the outpatient or the physician file. But for those of you that are really interested in dosing or timing of care, you might be interested in adding that to your overall algorithm for measuring chemotherapy.
Okay, do you want one last question?
Sure. Okay, we'll take one last question and then we'll break for lunch.
Can you identify opioids that are associated with using chemotherapy, such as the case of antiemetics?
So in order to identify those, again, I would direct you to the policies around when and how Medicare will reimburse for those types of drugs. Those would typically appear, I would think, in the Part D data. So I would look to that to start and go from there. Thank you all for your wonderful questions this morning. I think we have built in a 1-hour break, and we're right on time. So we will be returning at 1:15 Central Time, 2:15 Eastern Time, and we look forward to more of your questions this afternoon. Thank you.